by Dr. Rajesh Sinha on diabetes and cataract.
Thank you, ma'am, and thank you, Lalit sir, for having me in this webinar. This will be one of those rare talks on cataract, wherein I will not be showing any
Video.
video cataract surgery, because the basic idea is to increase awareness regarding cataract and its implications of cataract surgery, what all we should do in cases of diabetes. Now, diabetes, as we all know, that it affects your body from your head to toe, and it is a major cause of blindness. And cataract due to diabetes, again, is a big factor. Exact pathomechanism is not very well understood. A lot of studies have been done, a lot of work has been done, but yes, hyperglycemia has been associated with loss of lens transparency. And it has also been seen that if there is a rapid rise in blood sugar, that can also increase the chance of loss of lens transparency. And if there is a rapid glycemic control, in those cases also they have found that there has been lens opacification. The prevalence, as far as world is concerned, the diabetes prevalence is increasing, and in India, it is increasing to a very great extent. It's a major health problem these days. The global prevalence of diabetes was 2.8% in 2000, which is expected to reach 4.4% by 2030, which is almost double of that. The total number of people with diabetes worldwide over 171 million in 2000, and it is expected to be 366 million in 2030, which is a huge number. And cataract also occurs at an earlier age, and that is why it is of a great significance. And overall, 1 out of 5 individuals wherein you are doing cataract surgery for a senile cataract, you will find that the person is a diabetic. That is what the data states. And the reason is this, that diabetics are very, very likely to develop cataract, 2 to 5 times more likely to develop cataract than their non-diabetic counterparts. And this risk may reach very high, 15 to 25 times in younger individuals. Younger diabetics who are less than 40 years of age are very prone to develop cataract. And even in pre-diabetic condition, the lens is, carries some risk to opacify. A lot of studies have been done in terms of preventing cataract because of diabetes, and people have worked on pathomechanism, and so many agents have been used, which have worked on polyol pathways, works on glycation, antioxidants have been used, aldose reductase inhibitors have been used, but all these have been done in animal models, and till date, as of now, it does have academic value only and does not have any clinical significance as far as prevention of cataract in diabetics is concerned. The only thing that again holds true as in any other condition, and that is glycemic control. Now, as far as pattern of presentation is concerned, it can present like a typical snowflake cataract, but that is seen only particularly in young individuals, particularly when there's a rapid onset and progression due to sudden increase in blood sugar levels, rapid increase in blood sugar level, rapid opacification of lens, and that results in snowflake cataract. Otherwise, in routine diabetics, what happens that at an earlier age, you get to see patients with cataract. These diabetic cataracts have some uniqueness in it because diabetes is a disorder of basement membrane. So it works on the lens capsule, makes it thick, makes it fragile, and that one feels while doing capsulorhexis. And of course, the nucleus is quite hard and leathery in nature. The question is, whenever a patient comes to you, you have to think about it. And the most important thing that we have been discussing from the very first talk is when should we operate in a case of cataract in a person who is diabetic. And if what is most important is that good control of blood sugar should be done. Now, earlier approach was to wait for the time till the time you are able to see the retina and manage the retina. People used to wait and not do cataract surgery because people used to feel that there's risk of progression of diabetic retinopathy. But these days, because of everything, because of advancement in everything, advancement in the field of cataract surgery, advancement in the field of retinal management, people prefer earlier surgery so that better retinal evaluation and better management is possible. Is my voice clear? It's showing low internet.
No, yeah,
Is it
now
okay?
it is okay. There was a
Yeah.
slight this thing, otherwise it's fine.
Now, as far as preoperative consideration is concerned, it is, as I said, that there should be a good glycemic control. A lot of discussion was done in the earlier talk that what should be the final value. And based on all those discussions, actually, I have modified this slide and I have made it random blood sugar as less than 200 milligram percent, which Lalit sir was also mentioning that we can consider. And fasting sugar, as discussed, should be less than 140 and HbA1c should be less than 7. And that is a good glycemic control for a cataract surgery. There shouldn't be any evidence of ocular or periocular infection which a diabetic is prone to. And if there's a pre-existing PDR, if there are neovascular fronts, one can do a PRP and then go ahead with cataract surgery. And when lens opacity is precluding PRP, then lens surgery should be done. And then, of course, immediately after that, people can do manage the retinal problem. It can be combined with intravitreal injections like anti-VEGF and steroid. And many times, cases wherein there are macular edema, people do prefer combining the two procedures. As far as method of surgery is concerned, there are various methods of cataract surgery, but phacoemulsification is preferred because, particularly in diabetics, because smaller incision size and shorter surgical time decreases inflammation and less breakdown of blood-ocular barrier. And that is helpful because that will reduce the risk of anterior chamber inflammation and the risk of further complications in terms of CME, etc. And in the back, IOL implantation is preferred. One should be very careful in managing these cases. Try to prevent PCR as far as possible. In a small non-dilating pupil, one should always try to dilate it and not do any adventures. Use intracameral adrenaline, iris retractors, or pupil enlarging devices. And because there is some risk of anterior capsular phimosis, one should go for a slightly larger capsular excess. Also, because nucleus is very hard, but it should be smaller than the optic size. So something about normally what we do is we do it between 4.8 to 5 millimeters, but in these cases, we should go for about 5.5, 5.6 millimeter of capsular excess. And these are some of the, non-dilating pupil is an issue in diabetics, and we can use iris retractors or we can use Mediugan ring to enlarge the pupil. As far as the choice of intraocular lens is concerned, a large diameter IOL, 6.5 millimeter optic is always preferable. As in these cases, there's greater chance of PCO. So the optic design, which helps, which most of us are using these days, hydrophobic acrylic lenses with square edge optic design is the one which is preferred. If somebody is having a mild diabetic retinopathy or anything like that, then in that case, it is always better to use monofocal intraocular lenses because in a multifocal lens, if somebody develops a diabetic retinopathy, he will have a lot of photic phenomenon. And one thing is, one thing one should make sure that iris claw lens should be avoided. It is recommended. It is there in literature that iris claw lens should not be implanted because in future one can have iris. First of all, it can cause inflammation. Secondly, there can be NVI in future because of diabetic retinopathy, and all these things can jeopardize the success. As far as post-operative consideration is concerned, frequent topical steroid should be given. No systemic steroid because it will increase the blood sugar level. Frequent topical steroid to manage AC reaction because they are prone to develop high AC reaction. There is definite risk of CME and risk of progression of retinopathy and maculopathy, which is why a detailed fundus evaluation should be done immediately after the surgery. Intravitreal steroid has been combined. People do combine intravitreal injections. Sometimes if there's a macular edema and the patient has to undergo cataract surgery for further evaluation and more management, then in that case, intravitreal steroid has been used to reduce the macular edema. There are some depot preparations. There are some preparations available which can be used with cataract surgery and that can reduce the macular edema in the post-op period. Intravitreal injections of bevacizumab or other anti-VEGFs have also been used in order to reduce the complication. As far as complication is concerned, corneal edema is one thing which Dr. Namta was also mentioning, that endothelium does get affected, and most of the part of the cornea is affected in diabetics. But because of affection of endothelium, because of the less count, because of the altered morphology, because the coefficient of variation it gets affected, corneal edema can be there in these cases, even without using much phaco energy, and that has to be handled. PCO can be seen more often in diabetics because of associated subtle inflammation that can be there on a long term. Then cystoid macular edema and iritis again can be there. And if it's because in an uncomplicated surgery, but if it's a complicated surgery, then everything becomes more severe in diabetics, particularly if it's not well controlled. And as I said, that associated corneal problem, if there's an associated corneal problem in these diabetics, then that can further lead to complications and endothelial damage. Tonic and myotic pupil can cause a lot of problems by doing surgery. And as Dr. Pandey was also mentioning about the open angle glaucoma, there is enough material in the literature that suggests that there is association of open angle glaucoma along with cataract in these diabetic patients. So we have to keep this thing in mind. And as far as visual prognosis is concerned, if the patient is diabetic, not having any retinopathy, nothing like that, then it's good. You can have a very good vision and the patient will be very happy. But if there is a, say, proliferative diabetic retinopathy, then there's definite risk of progression. So especially in poor glycemic control. So immediately one should go ahead and plan a retinal evaluation immediately after the cataract surgery. So in conclusion, there are so many things that we can keep discussing about cataract and cataract in diabetics, but I would just like to conclude here by saying that the basic aim of doing this webinar is to increase awareness regarding good glycemic control, and that is very essential in order to have a good outcome of cataract surgery in a case of diabetes. And of course, as far as surgery is concerned, it should be done by a small incision and minimal manipulation so that there's less post-op reaction and cystoid macular edema. Sometimes you do have a confusion as far as the cystoid macular edema, which is Irwin gas syndrome, which is pseudophakic, and CSME, which can be seen in diabetic retinopathy. And that can be differentiated by doing a fluorescein angiography when you get a petalloid appearance, that is Irwin gas syndrome, and if you have a diffuse or focal leak, that can be basically because of CSME. And of course, there are retina people who can always differentiate these. And what is most important, and what was the aim of doing this webinar, was to increase awareness amongst everyone, amongst the ophthalmologists, amongst the anterior segment, posterior segment surgeons, amongst the public, regarding overall good control of blood sugar level, so that we can have a good overall outcome of cataract surgery and a good overall ocular health. Thank you very much for your patience.